When I'm speaking about occupational therapy and physical therapy, I'm speaking about two distinct disciplines. They are not the same, they're different. And their interventions, though they may look the same, they're different according to the provider, according to their scope of practice, according to their expertise, their experience level, according to what they're bringing to the patient and what the patient is coming in with. And so when we describe and we discuss occupational therapy and physical therapy, I want to lay that foundation that they're two distinct disciplines. And a lot of what their interventions look like depends a lot on who's in the room with them and their own expertise that they're bringing to the case. The best teacher has been the people that I've served. I had the honor to serve, who have shared their stories with me. And like the woman that shared her story today, I thanked her immensely for this story. But I'll be honest with you, because it left me speechless, I have something important to share with you all today. When I first started in this work, I was really excited about the potential to impact women's health in a really meaningful way. Today, that hope has been diminished somewhat. When you go through her case with me, you'll understand why I say that. The story that was shared with me today was a young woman who had three pregnancies, two healthy children. During her third pregnancy, she started out her story by describing that everything was difficult from the get-go. She had very severe nausea and vomiting. The students who have been with me and the participants who have taken my course know that as hyperemesis gravidarum during the first 5 weeks of her pregnancy. And it didn't really get better from there. When I started to hear her story, I was braced for kind of a myriad of things. And my hope that I had at the beginning was that discussions like this would be obsolete in the future. By the end of her story, that hope has been diminished somewhat. During her pregnancy, she dealt with cholestasis. And cholestasis is a disorder that really primarily affects the liver. It's a liver disease. It's a problem where bile is not filtered very well through the liver, through the gallbladder, and it can be quite painful. In her case, it caused her to be induced at 37 weeks. If left untreated, cholestasis could actually cause premature birth. It can cause fetal death, cause a myriad of issues. It could cause meconium fluid, a lot of different things. And so her physicians were right in inducing her early. Her birth was actually pretty uneventful. She delivered a healthy baby. She was healthy, other than high blood pressure at some point during a labor and delivery. She was actually fine. Her baby was fine, and she was sent home. So at the beginning, she communicated that she had two children that she also was caring for. 3 years old, and I believe the oldest was 7. But she had enough support at home. She had her mom and her spouse to look after the children. And of course, she had the newborn, but everything was pretty much okay. Everything didn't, really seem like it was out of order. She was doing fine. For the most part, for the first few days. She started to feel some tightness in her throat. That's really the only thing that she could really say was off. She experienced some swelling in her feet, but she was taking daily blood pressures because she did remember that nursing in the hospital had told her what to look out for, signs and symptoms of preeclampsia, swelling in the feet and hands, right upper quadrant pain, things like that. But nothing seemed off in terms of this tightness that she was feeling in her throat. And she described it around her neck. And what her spouse and her mom thought was that maybe she was actually holding the baby in a weird position. And so she was having this pain just right around her throat area. And she couldn't really quite explain it. And so, she wasn't really given a lot of guidance as to what could have been the problem from the people that were in the home with her. And so she didn't really think to call anyone or alert her medical team. One day she's going upstairs, and during the mid step in the middle, she actually became short of breath halfway up the stairs in her home. It was this particular day that her sister happened to call her. Her sister is a nurse, and she told her what was going on. Her sister was just checking in, and she was actually about to lie down for a nap. And her sister asked her to take her blood pressure. She asked her, what is your blood pressure? Well, the woman told her blood pressure, and at that time, it was 140 over 80. Her heart rate was in the 40s. Her sister didn't think that that was right, so she had her take it again. Well, this woman, which is very odd, is very unusual for me to hear. She actually happened to have another blood pressure cuff, so she took it on another arm, and it was 156 over 80, and her heart rate had decreased down to 46. So her sister said to call her doctor. Once she arrived at the hospital, her systolic blood pressure was well above 160, and her heart rate had decreased to the low 40s. While at the hospital, she was diagnosed with postpartum preeclampsia and acute heart failure. And up until this point, she felt like she didn't have the symptoms of the postpartum preeclampsia that was given to her as education in the hospital. The right upper quadrant pain. She didn't really have a lot of swelling in her hands and her face. She didn't feel like her feet were that swollen enough to alert the medical team. While in the hospital, while on IV magnesium sulfate, and for those who know this, who are familiar with this, and you've heard me teach this before, IV magnesium sulfate is given definitely with regards to preeclampsia, given to those individuals to prevent eclampsia or seizures or even a stroke. She had a 5-minute syncope episode when the nurse in the hospital got her up out of bed to go to the bathroom. Now, for those of you who have heard me say this, and I'm going to say this for those of you who haven't, is that anyone who's on IV magnesium sulfate, typically a contraindication to get out of bed for any reason. We're usually supplying, or the nurse on the unit already has this, but they should have a bedside commode so that the person can transfer and not stand up. IV magnesium sulfate is known to reduce the blood pressure and cause orthostatic hypotension. It was given to someone with severe blood pressure, so you know that it's driving their blood pressure down. In this case, this woman was being assisted to the bathroom, and she fainted. She doesn't remember anything out of that. She completely blacked out, and her medical team had to transport her to back to bed. And so I want to really talk about this and stop here and kind of engage with people in the room and actually call a panel of OTs up to discuss this case. But I want to first give my input as a physical therapist, one who's treated across multiple settings, one who's also seen kind of every phase of pregnancy and postpartum, whether that's during pregnancy and outpatient as a women's health, pelvic health therapist, inpatient during high-risk pregnancy, immediately postpartum, and then outpatient and home health with this particular patient population. And I'm choosing to focus on this population today to really drive home a point about what really is the difference between an occupational therapist and a physical therapist. We've already established that they're two different disciplines. They're not interventions, but using a case-based example, what really is the core difference between our approaches? And I could tell you right now from that case, I can say that I lost a little hope after the woman shared her story, because it happened 4 months ago in 2023. And the fact that we're still having discussions, apparently there's a lot of barriers still to providing our services in the hospital, whether that be a triage issue, whether that's priority, whether we have determined that these patients or these clients or these people really are a priority enough to deserve our attention as acute care occupational and physical therapists, or whether it's some in our own field that have used the term walkie-talkies to describe people who are walking, who are talking, who don't seem to need any kind of assistance with transfers, any kind of assistance with ambulation. What I'm fearful of is that there will continue to be this incredible gap in care and education to this population that is primarily caused by those in our field, by those in our discipline. And this is not to discount that there are barriers that are external to us as occupational therapists and physical therapists. There's going to be barriers. You have the OB field that has been around for years, centuries, if you will, that has run like a well-oiled machine without us. But I think that if we don't establish a foundation for both of our roles within pelvic health and maternal health, we are going to write ourselves out of the script of intervening for a population that can use us yesterday, last year, 10 years ago, 20 years ago, and so forth. And so I'm hoping that with this talk, we come together as a panel, as a room, as a virtual audience, whenever you're listening to this, and you can really appreciate the role that both of us have and how we collectively need to work together to ensure that stories like this that happened 4 months ago, there was a lot of negligence in this case, and I don't use that word lightly. The hospital was negligent. The nurse that got this person up on IV magnesium sulfate was negligent. And the medical team as a whole for not including rehabilitation services for someone who's a mother of 3, has acute heart failure and postpartum preeclampsia, to still not be sent home with rehab services or access to rehab is negligence. And so we're going to discuss as a panel. If you'll allow me, I'll invite my guests up to really get their thoughts as occupational therapists of what they would have done. But I could tell you as a physical therapist, I would have done this. I would have taken vital signs on this person at rest, which their medical team was doing, but then after activity. And this is not new when you hear this from me. You all know that as a physical therapist, we do this for every patient population, or we should, who has been in the hospital, may have lost significant amount of blood, may have a home environment that they're going to be returning to after a major change in their function. And you have heard me advocate that we should be taking active vital signs meaning within a very short time span of that person performing an activity. If that would have been done, I can guarantee you there would have been some indication that this person may be encountering some challenges going up a flight of stairs, caring for 3 children at home, doing things around her house, self-care, ADL activity, meal prepping, whatever it was, even with the support that she had, it may have told us something. The other thing I didn't mention is that this person's BNP was in the 700s. We know anything over 400 BNP indicates heart failure. And so as an acute care therapist, I hope I would have looked at her labs, looked at her hemoglobin, and looked at other things that maybe her medical team was missing so that I could actually advocate for her to have more support or more surveillance. The third thing I would have done is I would have had someone on her care team give her a phone call 2 days after she gave birth and that she was home. I think too few of us are involved with this patient population within 0 to 6 weeks. And within 0 to 6 weeks, over half of maternal deaths are occurring. And so when I talk about a phone call or a routine visit, that could be from a nurse, but I think it could also be from someone who's a rehab professional. And I can think of no better rehab professional that could assess someone's occupations at home as an occupational therapist. And I've developed a PDF with two incredibly talented individuals that I am absolutely overjoyed. I think one of them is in the room joining us today. But this is a handout. And if any of you are interested in receiving this handout, please indicate so if you're with us live in the chat. But this is a handout that really kind of lays out the differences between our services. There will be some overlap. You'll actually see this going through, but it divides the settings between hospital, home, and the clinic. And so their pelvic health overall, because they're including populations after birth and after pelvic surgery, but it ends with interventions that you'll probably see in both of our fields. And that's where we'll manually assess and treat body systems, including pelvic floor, deep core, intra-abdominal pressure, strength, range of motion, and sensation as it impacts quality of life across all settings in the hospital, home, and outpatient. And my emphasis here on body systems is this. As physical therapists, we describe ourselves as movement system experts. When I say to this in the room, and I want you to really understand the emphasis on the movement system, is that it's impacted by every organ in the body. The cardiovascular system is part of the movement system. The neuro system is part of the movement system. The musculoskeletal system is part of the movement system. And so if we are not taking the time to assess body systems as they relate to someone who's gone through a birth or a pelvic event or a pelvic surgery, then how do we call ourselves movement system experts? How do we do that?
Thank you, Rebecca, for sharing that case study. As we was listening, I was jotting down my notes, and then when you pulled up the cheat sheet, I'll call it, I was like, I have all of that stuff written down. So from an occupational therapy standpoint, as you mentioned, Rebecca, yes, vital signs, assessing those is very important. But I also was just thinking about, as you mentioned, she's a newborn mom. So she's already had congestive heart failure, acute diagnosis, shortness of breath. So I'm thinking about energy conservation. So she has to return back to her home. So maybe I'm already thinking about baby wearing. You know, is that something that she's been educated on? If not, providing education on baby wearing, so that frees up her hand, because that's, again, that's energy that she's using, that strength that's required to hold the baby while probably ambulating up and down the steps. So as an OT, I am looking at baby wearing, and not only baby wearing, but looking at the type of baby wearing type equipment that is out there. What is going to be something that the mom is going to feel not only be supportive, but something that she feel really independent in being able to doff and don herself as well. I'm also thinking about the baby's room, looking at the changing station. How far down does mom have to bend down to bring the baby down and pick the baby up? So again, we are, you know, using energy, having to do that. Do we need to elevate those surfaces to allow the mom to not expend so much energy? I am also looking at just lower body dressing. So reaching down to put socks on, reaching down to put her pants on. What type of adaptive or assistive devices that I can incorporate into her daily routine. Rebecca, you already mentioned, and please, my other OT colleagues, I can talk about this all day, so please feel free to interject.
I have a special question for Dr. Josie Jarvis and Lenise Beasley. Dr. Beasley is with us today. You keep continuing because you're talking about this time after she's already been diagnosed with heart failure, acute heart failure, and postpartum preeclampsia. So please continue.
So again, I'm looking at lower body dressing. So thinking about what type of assistive devices that I can introduce, a reacher, a socket, a dressing stick, anything that's preventing her from having to reach down or bring that leg up. So minimizing the amount of work that mom has to do. And then I definitely, we're thinking about the home environment. You know, we're asking those questions anyway on evaluation. So I'm getting into the bathroom. As Rebecca mentioned, I already have maybe the bedside commode or 3-in-1 commode. I also need to know, do you have a tub shower combination or do you have a walk-in shower? If it's a tub shower combination, do you primarily stand to do your bathing or shower, or are you getting down into the tub? Because again, that is energy that is required to get down and also to lift oneself up. So maybe we need to be introducing a tub shower transfer bench, or maybe even a shower chair. Again, anything that's keeping mom from having to expend so much energy, while also keeping her safe and minimizing risk of falls, because again, she may have an experience of shortness of breath while she's doing these activities. And then I'm also, like you mentioned, household management. What do you do in the house? Where are those items located? How can we minimize going up and down the steps? Perhaps, we may need to have a set of cleaning supplies on the upper floor, cleaning supplies on the main floor, cleaning supplies on the lower level. Thinking about how are we doing laundry? Are we sitting down as we're putting laundry in or taking laundry out? So those are all the things that I was kind of going in my head when I heard, the congestive heart failure and the shortness of breath. And then also educating mom, we talk about energy conservation, taking those rest breaks at the first sign of fatigue. A lot of times, as new mom, I remember being a new mom, I felt like that I could push through and do it all, not really understanding how much of a risk I was putting myself for injury, because I'm already sleep deprived. On top of that, and then again, going into the hospital and just having a baby, just the overall weakness that just came from carrying the baby. I wasn't as active as I once was prior to becoming pregnant. So I had to build that strength and that endurance and that tolerance back up. So definitely, again, just those are the things that first came to my mind as an occupational therapist when I am working with the perinatal population. So those who are in the hospital, acute care. I used to work in acute care. I'm no longer there. I'm now in outpatient pelvic floor, but I also see postpartum patients in my mobile clinic practice as well. So those are the things that came to mind as an occupational therapist for me when I was just thinking about her treatment plan and interventions that I would incorporate into the plan of care.
And Elle, you're the owner of Ground and Root Pelvic Floor Therapy Services,
Yes, I am.
Pelvic Health OT. You yourself, you have talked about your own pregnancy, your postpartum journey as well.
Yes.
And this next question is going to be for Dr. Josie Jarvis, because I do want Dr. Lanice Beasley to chime in on a specific question after. But Dr. Jarvis, I have a question for you. Okay. So with this case, laid out the case of this person, laid out their second hospital admission, and then Elle had a myriad of interventions that could have really been given the first time. My question specifically for you is has to actually do with before her first discharge. As an occupational therapist, if you just heard the laundry list that Elle laid out, which I think, Elle, to your point, all of those things matter. But a lot of the pushback that we receive as acute care occupational physical therapists is we're going to overwhelm this person. And yet fluid was overwhelming her heart. So my question to you, Dr. Jarvis, is from the lens of wherever you're coming from, and I do want to actually take some time and just give the audience an idea of who's actually going to just start speaking right now, because I'm a passionate follower and admirer of Dr. Jarvis's work. She's been a generalist OT in Washington State since 2016. She specializes in client advocacy and occupation-based services in traditional practice, informed by latest developments in occupational science. So she's an informed occupational science-based OT. Thank you so much for your time. And please, what would you have done before this person was discharged?
Right. So I think so much of the importance of this conversation, it does happen right before we even get the opportunity to interact or be known, right? We have to have some sort of touch point that allows us to be aware of contextually, like where this is going on. And I am so grateful to be in this setting. And I'm so grateful to share this panel with collaborative therapists, because I think working on the front lines in acute care therapy as well, the metaphor that I use sometimes is it feels like today and amid our COVID landscape that we're evolving with a hospital system together. Sometimes it feels like we're trying to triage on the deck of the Titanic. I don't know about what you guys think and feel. It is a very complex system. So when you say worried about overwhelming our patients, oh man, I think everything is overwhelming at this point, right? We are in a state usually of hypervigilance, fight or flight, dysregulated nervous systems that play in. And I think sometimes it affects us just as how the healthcare system, our history, how it's progressed, how it's rapidly evolving. One of the theories that's been helpful to me is there's a theory called complexity and chaos theory that nursing actually uses right now, this leadership theory model to predict how staffing ratios are evolving. I've sent it to you once, Rebecca, and we can maybe do a discussion about it for your community at another time, that we're used to with how we went to school in the acute and post-acute care environment. So much of the worldview on building our science bases and delegating plans of care from a more traditional prior model than we're currently living through now, that was based on trying to standardize and universalize our science base across politicians. Like, well, we hear a lot about standards of care and standardized protocols. And I think what's really important to know about some of the differences between occupational therapy and physical therapy and what we can offer the acute care team today is to acknowledge some of our positioning within history of this US social care system. And often when you want to work with an occupational therapist, and I would say a physical therapist as well on the team, especially as we're delegating more and more to nursing, and honestly, they might start delegating back to us because I think nursing might be more expensive than us going forward in some cases. So we may actually have a little bit of wiggle room to be involved in some cases. It kind of depends on what nursing maybe doesn't want to do. We'll get an opportunity. But I think OT has always been a good discipline to bring in when things aren't going as expected. I actually think of us as the adaptive therapist. That's kind of how I like to frame a lot the specialty, and how I collaborate really well with the nursing and physical therapy terms is I try to understand the cultural context around me, and I get to know clients and my colleagues as occupational beings. And I apologize if this is going a little bit offhand, and I promise to circle back. So to understand like how occupational therapists are trained to think, because it's the invisible stuff that distinguishes a physical therapist and an occupational therapist. If you're going based on the visual observation of a human being in a pair of scrubs that's helping somebody to the bathroom, it's very difficult to tell the difference between a CNA, an LPN, an RN, a doula, a midwife, a PT, and OT, just by looking at them. We're human beings moving and performing, yes, occupations, but why we are staffed in these facilities is because we've been trained to think about challenges in specific ways and to look for opportunities for solutions using specific theories and ways of thinking. And so the way an OT could start, especially I'm speaking in a way that's informed by the Occupational Therapy Practice Framework 4th edition, which hopefully not to be too annoying, Rebecca. There are some times when occupational therapy, if it's falling in alignment with the occupational therapy domain and process, which is how AOTA would like all occupational therapists and occupational therapy assistants to be developing our interventions intentionally. If you follow that process as it is outlined, we're actually not really enabled in that process to pre-decide what we would do for a client. So it would actually be important to first, before that first admission, our role as occupational therapists would really need to start at more that systemic advocacy level of explaining what value a hospital system could gain from including a physical therapist and occupational therapist in a
Speech therapist.
No, on a floor that would support maternal I have not actually, even though I've worked in acute care for several years now in multiple like trauma size hospitals and small podunk hospitals, in my career, I haven't gotten an order for an OT to see somebody on a labor delivery floor, which is why I do think that there are systemic factors going into, so like you're asking about what do we do before we see this patient? First, we need to have a system that would enable a physical or occupational therapist to respond to an order. So that would have to start with discussions above hand. And unfortunately, I think we're at a place with discord between our respective professions and disciplines that we actually have to go to the core theoretical and philosophical level of what differentiates our professions. Some things that are helpful for me in my advocacy and collaboration is I personally view occupational therapy as more outside the body specialist. And in my specific case, I'm not a movement expert and specialist. So if we had a movement expert and specialist on the team, and especially one that I could respectfully have a strong working relationship with, much of what you mentioned, Rebecca, I would take off my plate because if I knew that you had the vital signs down and physical therapy was going to go through some of those things that don't change, honestly, like any patient with cardiac issues that you explained, I would want anyone to repeat and go over again and again the importance of taking vitals, understand energy levels. With how I've been trained and using the OTPF and how I've seen occupational therapy evolve in other countries, OTs collaborate just as much with social workers as they do with nurses and physical therapists. I would be taking into account the habitat of this individual, and I would take all those features of like, I'm overwhelmed about this client just knowing how many kids she has at home, let alone the symptoms she has. So I would be looking at, okay, does she have clear pathways at home? How common is the physical therapist telling me that when they did vital signs, and if the physical therapist happened to walk them to the bathroom, I'm not going to get mad at that because that's helpful data for me. I'm going to get that data and then I'm going to understand. And then I might consult the cardiologist and say, hey, so I guess she's having a syncopal episode. Is that in any way connected to hydration? And like with what Elle was saying too, I would be like, oh man, we need to get her low sugar Gatorades in the home. And we would probably be needing to coach her through some of the her overwhelm and the emotional regulation and her sensory experiences. The way I do it is I find out what the physical therapists I'm working in, what they feel like their zones of excellence are. And even those things are technically in my national scope and are things that me as a human are capable of providing many different types of patients I work with, I'm going to respectfully delegate that so that we don't have duplicate billing in our documentation. And I'm going to look at all those different contextual areas in the OTPF that are in my domain and process. I'm going to work collaboratively with the patient to come up with customized adaptations that are exactly specific to her. And I might even ask her a little bit about her trauma history. And I would take into account some of those multiculturally mindful factors about, it would matter if this pregnancy was in a result of a perpetual sexual assault experience, right? Like I would need to get a really robust occupational history of this content. And then I would work on coming up with the just right challenge for that home. And I would try not to be overwhelming, but I also wouldn't be in denial about what structural supports and advocacy she would need to experience those reduced risk of readmission within 30 days. And I would be kind of being a bulldog with the care planning team and trying to advocate on her behalf when she couldn't maybe be in a position to speak up for herself at that moment.
Thank you. Thank you, Dr. Jarvis. I want to kind of go off of what Dr. Jarvis said before, and she alluded to something that Elle, I didn't catch this before. So when you were talking about dehydration, I want to make clear that this syncopal episode that occurred in the hospital was due to IV magnesium sulfate. She was not feeling dizzy at home before she actually went home. And that's important for the audience to also realize as well, is that this drug that she was given should have been known by the nursing team to be enough of an indication to not get her out of bed. It's enough of an indication for our field as occupational and physical therapists that work in the hospital to not get someone out of bed and do activity, because that person loses consciousness very, very quickly just with walking. So it causes exertional and orthostatic hypotension, and it lasted for over 5 minutes. And be out cold for 5 minutes is a very long time. And so you're absolutely right. On the back end, I agree with you. I would have been giving something just to help with any kind of ensuing dehydration, any anemia, anything that this person would have experienced on the back end. But to Dr. Jarvis's point, there are structural reasons why we're not even in the room and why we have to have these conversations now. But my effort has been to really reframe this population as just what we both say in our disciplines. Being able to treat anyone who walks into the hospital is something that we both, I think, have as a flagship as occupational and physical therapists, except when it comes to pregnancy and birth. And Dr. Beasley, I'd like to have you kind of close this off at least as a panel discussion before we open it up to the room. Dr. Beasley, you are a wife, you're a mom of 3. You had a home birth with twins, and you're a women's health OT, health coach, and birth advocate. I want to share the last part of this case with you and get your input on this. The last part of this case was probably what left me my heartstrings really pulled, Dr. Beasley. And it's very fresh because I just heard this case today, completely changed the course of this talk. But when this mom was telling me her story 4 months out, what she wasn't saying was completely written on her face. The thing that she left me with was, after my response of what I would have done, that was kind of the premise of this podcast, was she was going to be sharing her story, and then I would have given her what I would have done as a PT. After I said that, she said this. She said, had someone checked my vital signs or asked me about stuff at home, or even just recognized that even though I had what a lot of women don't have, which is 2 adults in the house that were helping me, I wish someone would have taken into account that all 3 kids or all 3 of my children still needed my attention. And I've lost so much time. That was her words, that she lost so much time from the diagnosis, from going back in the hospital, from all the things that happened to her. She lost time, and you can't get time back. So my question to you, Dr. Beasley, is in terms of the mental health component, in terms of just addressing someone's mental health before they even leave the hospital, before they even have an encounter that like she had, before she has to even come back to the hospital, be readmitted, how could an occupational therapist, different than a physical therapist, address that component of that person's well-being?
Ooh, that's an excellent question. Well, I will speak in a couple lenses here. From my mom lens, my twins are only 10 months old, almost 10 months old. And from an OT perspective, as the primary parent, understanding the burden that is as a new mom and as a mom of 2 other littles, I would definitely start from a place of empathy there. And understanding what that mom's role is going to be now that they're going to be transitioning home. Because so much of the mental part is just that burden of knowing you have all of these responsibilities waiting for you when you get home. So helping mom figure out how she's going to delegate would probably be where I start. Understanding that now mom may not be the one who's doing the cooking, who's prepping meals, who is going to be responsible for pickup if the oldest child is going to school, who's going to be responsible for drop off, who's responsible for the 3-year-old. I think you said the other child was 3. Who's responsible for the 3-year-old? Are they at home? Are they in daycare? Those simple things are not all that simple to the mom who just had the baby, because they're still thinking about the care of their other children. So I think kind of starting there and figuring out what that mom's main responsibility is when they're the primary parent, and seeing how much of that load she can take off of her so that she can start addressing, okay, how am I feeling? Now that that's off my plate, how am I feeling? What do I need in order to feel like I can be the best mother that I can be, while also taking care of myself, finding time to do that, which can be very difficult after having a third child. And then just making sure that mom has a system or a person set up for when they are feeling overwhelmed. These are things that we as OTs work with our clients on all the time, is mindset and making sure that they have a support system, or what are their triggers? What are some of the things that they know overwhelm them? Is it some sensory overload going on? What are you doing to de-stress, decompress? These are all questions that we are more than capable of helping mom figure out before she leaves out of that hospital after having a baby.
That is so true and so well said. And thank you, first of all, for sharing your experience of having, 3 little ones yourself. You had a home birth, and I like to just kind of just take some time to acknowledge that, because you also have mentioned this to me, kind of in other forums that we've been in, Dr. Beasley, is that your birth, or your pregnancy rather, was classified as high risk, right? You were already pegged. And I like to leave you all with this, right? Because I think this goes without saying. Dr. Beasley, you advocated for yourself. You didn't allow yourself to be classified as a high-risk pregnancy, which automatically, if you're a mom with twins, in some hospitals, that's an automatic C-section. You had a home birth vaginal delivery with twins. So I want to emphasize that. And I want to also just, point out for anyone who may be listening to this, who can't see the video, is that Dr. Beasley, Elle Holmes, myself, we are all women of color. Dr. Jarvis,
I'm not
a woman of color.
All, but I am hopefully a case example that it's possible to be of settler descent and like total whiteness. Everybody has usually, like, there's something called mitochondrial Eve that I encourage everybody to look at. So if you subscribe to evolutionary theory by national selection, and that like not everyone agrees on that, that's okay. Yeah. But the Fertile Crescent, there's some part where Africa, we have kind of some connection to common ancestors, possibly from that client. So I think it's good if we understand that we're all interconnected in a family tree, and we can be allies and solidarity with each other. But yes,
Dr. Jarvis, yes, you're not a woman of color, and I agree with that. I absolutely agree with that. Actually, when I was 12 years old, did a project that was wholly rejected because it was to say that we actually are more connected via DNA than we are phenotypically. But my point in saying that is that we have women of color. The patient that I was speaking to today was not a woman of color, looked very much like Dr. Jarvis. And when I say and I speak and I teach and I talk about the maternal health disparities, what kind of shocked me the most is that this was a person who'd be classified as a person who was low risk, every bit of a person who wouldn't fall into that disparity category. And yet she couldn't find the words to advocate for herself. It was her sister, who was a nurse, who had to. So are we seeing this rise in maternal health disparities and outcomes actually being indicative that we are both needed in the room? Because just like women of color are experiencing around the country, women who are white are also experiencing these horrendous, very troublesome outcomes, and they're not advocating for themselves. And so if we're cutting ourselves as a profession out of maternal health care, especially in the hospital when it's needed so much, and we're cutting ourselves out of the home environment where we're also needed, and we're just isolating ourselves to this outpatient care and then squabbling over who gets the pelvis, I want everyone who listens to this to pay attention very closely. That is a sign that we have not been able to separate from the colonial roots of segregating parts of the body and owning it. When we choose to classify a discipline as being an owner of a part of the body, we're colonizing that human being. We're creating barriers that shouldn't exist between them getting the care that they need. That is colonialism, that's segregation, that's a sign of I would say professional racism. I have to use these ism terms to drive home the point that it is actually harmful to people to be so colonial in how we treat and how we serve these populations. And if we don't break that, then we are only hurting people. Elle, I'll start with you if you don't mind.
I always say that our two disciplines is more collaborative than competitive. And as Josie mentioned, I love being in the same space with my physical therapy counterparts because I feel like we can provide such a more robust plan of care for the individual that's in front of us, and not necessarily, again, based on discipline specifics, but just our own individualized way of thinking, our own lived experiences and our own life experiences, we're able to also bring into that conversation and plan of care. So that is how I see our roles, more collaborative than competitive. And when we work together, we all toss around that term holistic. I feel like that's when we truly can provide holistic care. When we're able to kind of bring everything together in our brains and our resources together. So those are my thoughts.
Oh, thank you so much, Dr. Jarvis.
I'm so excited about this, and I want to give a big shout out to one of my heroes in the occupational science and occupational therapy world. That I think the beautiful thing about occupational science is it's the science of everyday living, and it's about it studies occupational developments, which, like, I was trained as a field biologist prior to going into OT, and field biology, it's really clear that animals kind of have occupations, right? When we're trying to understand a creature, you're going to look at where are they finding food? Where are they sleeping? Where do they feel safe? Where do they come out? Are they nocturnal or are they diurnal? And that's kind of how OT is, or at least my style of OT is looking at that whole habitat. And there's a lot of educational disparities between different schools of thought that link back towards the systemic hostility towards people with uteruses and 2X chromosomes and things. We've been largely systemically excluded from developing, that's also in the medical realm as well. There's a lot of resistance, especially to women of color, ascending through the academic hierarchy. And a lot of people are still navigating those challenges today. What I find is those of us that are working in the field, we tend to have more common causes, working together and aligning and building a collaborative crew. If you think of, like, I use the Titanic metaphor, my hope for US healthcare is we go from Titanics to arcs and networks of lifeboats, individualized lifeboats, where everybody has what they need. And it takes a whole collaborative crew to do that. A competitive crew, it's harder to get that outcome. The Titanic was not successful. Lots of negative discharge outcomes from that try to attempt at a scientifically robust craft, right? We're trying to make scientifically robust crafts in times of rapid change and fluctuation. And, I never identified as a pelvic floor therapist. I'm still struggling with that, even though I think every OT is a pelvic floor therapist because we work with voiding of bowel and bladder and the context around where that can happen safely and humanely, hopefully in a community and not just in an institutional setting. But it really has taken collaborating with physical therapists to do that. And Rebecca, I would say that we've kind of collaborated even on a pelvic floor case in the community under exceptionally strained systems. I've gotten consent from this case study, and I won't name her in this context, but she had adverse post-health thing with a family of 7. And then going through dysregulation of grief of an active trial taking place in my community. And I had to reach out to Dr. Seagraves in the Pelvic Health Network to get this more basic medical knowledge that I'm not a specialist in. Dr. Rebecca Seagraves is a specialist, in addition to having lived experience as a woman of color that I don't have. So even without like in this case, Elle and Lanice, we have the same training in theory, but you have lived experience as a woman of color that I don't. So I have to even consult you within my own discipline to get some of the insight on how to accommodate. And what you said, Lanice, I was so excited about what you were saying about how do we accommodate the whole family, the whole ecosystem at home as an OT. What I did as a community-based OT in emerging practice that's informed by occupational justice, occupational science, and occupational consciousness, which is what I would love everyone here to look at, a free article by Dr. Elwane Romagundo from South Africa and her like really profound research on the occupations of play in a post-AIDS context. All of this context matters. But I helped provide and supported this pelvic health client, not by touching her areas at all or taking vitals, even though I made sure to get supports to get her vitals like more like a social worker might. But she actually needed me to help feel secure about her kids during the trial. So I built a sensory room within the court trial and made sure they had comfort tools. And that was knowing and being responsive as an ally, right? But occupational science taught me how to do that, not anything in acute care and taking vital signs. So it's important, I think, for PTs to know that OT education is very different than PT education. And we get just as much training in the DSM and the social sciences. Physical sciences are like 10, 15%. And it sounds like with PT, it's like 90%. So I'm going to stop talking from there, but thank you for letting me share some space. And I will send some links possibly to the occupational consciousness if there's interest amongst this community.
Absolutely. Thank you, Dr. Jarvis. Close us out for this panel, Dr. Beasley.
Yeah, honestly, thank y'all so much for even allowing me to, thank you, Rebecca, for even allowing me to be here. And Elle and Josephine, everything that you guys said was spot on. I think the one thing that I really want to hone in on is the fact that people, women who are giving birth are at risk for dying because they don't know what they don't know. And we as occupational therapists and physical therapists have the opportunity to help them be the best advocate for themselves. And that starts with just giving them the knowledge. It also starts with not only giving the knowledge to the patients, but giving the knowledge to the providers, to the OBs, to the chiros, to everybody, the doulas, the midwives, everyone, because this is an issue. The maternal healthcare crisis is an issue that is really near and dear to my heart, which is why I did choose to go the midwifery route, but I shouldn't have had to. And nobody should have to, just because of their fear of not being able to go home with their child. So my biggest encouragement is to advocate, and educate.
Thank you all so much for your time. Please, if you can, share your contact information, whether it's across social media handles where people can connect with you. All of you have shared resources just in the form of just immense, tremendous education. And so I want to personally thank you all for being a part of this panel discussion. Rebecca Downs is a Doctor of Occupational Therapy student. So I'm going to actually just be inviting her up. I'd like her to just kind of give some insight into maybe the backstory behind this handout. This is a handout that I'm hoping to educate not just our communities with, our communities of rehab professionals, or communities of people who are giving birth, who will be in the hospital if they want to advocate for themselves to receive services before they go home. They can advocate to have us on their team, especially on a team where they don't historically offer OT or PT services in the hospital or the home. But this is also going to be a tool that we can use to educate those providers so that there's not so much pushback between us getting on the team in the first place, and also to educate our colleagues in acute care who don't know what they don't know either in terms of caring for this population, and our colleagues in home health and in the clinic, just so that they're aware of by the time they get a referral for someone, it's usually too late. These people have lost tremendous amounts of time. They're home with having to care for their newborn, maybe other children. and they're continuing to lose more time if they have to wait for your schedule to open up as an outpatient pelvic health therapist. So I ask you to please, if this handout you think at all will be of service to you, to understand the differences between our professions, but really to get a sense of the impact that we both have, please let us know if you would like a copy of this handout. And without further ado, I'm going to find uh, the soon-to-be Dr. Downs and just ask her to just join me just for a very short discussion to give a little bit of background on this handout.
Thank you so much for inviting me. It's kind of been a sensitive topic, and I feel like there's historically been some tension between OT and PT, and I think all of us here can agree that we want to collaborate and work together and focus on our commonalities and our differences and see how we can bring different things to the table. Basically, the background behind this was I was actually like on my way to Texas for my pelvic health rotation. It's really difficult for OTs to find a pelvic health rotation because there's just not as many of us, and it's just emerging. But I think more OTs are starting to take pelvic health students. But something I've been passionate about is like language, as Rebecca, Dr. Seagraves can probably attest to. And I'm trying to figure out how to help us all recognize pelvic health PTs and pelvic health OTs who both practice pelvic floor therapy, because it's historically a lot of people say pelvic PT, and it's kind of like my whole point on Instagram and everywhere. I try to like tell people to use the phrases pelvic OT, pelvic PT, or pelvic floor therapy if you're referring to the profession as a whole. I'm kind of learning that the language isn't as important because we all have the same desires to help support people in their pelvic health journeys. So what happened was I commented on someone's post, and I could have done a lot better. I could have been a lot more gracious. But I kind of asked them gently, can you please try to use pelvic floor therapy? And I need to improve on this because it doesn't feel as important. But Dr. Seagraves has been really validating. And then there's kind of just was a lot of contention between us, me and this PT, because I think a better way to go about it is educating people that simply OTs also provide pelvic floor therapy, and not just asking you change your language, but explaining why OTs are here and what we provide versus what PTs provide and what we all both provide. So that's kind of when Dr. Seagraves reached out to us and asked us all to collaborate on this. Danica Viola is also one of the authors. She's also like pretty passionate about language and how we refer to the profession. So that's kind of the background. Something I've learned in my field work is we just have a lot to learn from each other. I have an OT as my CI, obviously, and she's learned a lot of her skills from PTs. And then other PTs that we work with have learned a lot of skills from us. And basically it is just really collaborative. I have a hard time distinguishing the difference between OT and PT because for me, it'd be wrong to say PTs aren't holistic because I received pelvic PT myself and she provides therapy in a really similar way that I would. So I feel like there is a lot of overlap. So I'm really grateful that we were able to write this paper or this handout to distinguish the differences and also the similarities. And I think all of us can teach each other skills.
What was beautiful about this whole scenario is it came really out of contention. And we even chatted a little bit on Instagram. Like there's a lot of contention around this, but at the end of the day, if we can all really dig deep, our patients, our clients, the people that we're serving could care less what the letters behind our name are, could care less if it's an O before the T, as Lindsay Vestal has said. in podcasts that I've listened to her, could care less if there's a P before the T, right? What they care about is their heart can't pump enough blood to their brain, or they can't care for all three children the same way at home, or they're having difficulty with these huge impairments. And so, Becca, I mean, I follow you. You have over 26,000 followers on Instagram. You're everywhere. You're on LinkedIn. I'm incredibly a fan of your work. And I thought this would be a great opportunity to collaborate with this person who ended up not joining us on this handout. I wish that would have been different, but I really wanted to kind of at least tie our fields together to refocus what we're here for. In terms of this handout, how do you plan to make this available to people?
That's a really good question. I haven't thought about that. I definitely want to share it to my Instagram account, and then maybe to my professors, any PTs I know, like, I don't know, just kind of seeing who wants it, who's receptive.
Or even future students. I mean, there's not enough, I think, of us in academia who are preparing the next generation for collaborative care in women's health and maternal health and pelvic health. And so I think there's just a lot of upside for handouts like this to be created across all disciplines. We just need to have probably a better way to communicate our role, because as Dr. Jarvis alluded to, we're finding that our role is being compromised in terms of the perceived need of us in care across all settings, across all patient diagnoses. If there's a perceived need that we don't really need OT on the team, we really don't need PT on the team, then that really does decrease the amount of reach that we all have. So if we don't get this right together, kind of alluding to, there's going to be a bigger issue at hand. There's going to be a bigger issue affecting both of our fields and how we thrive as two separate disciplines. And so if there's not a perceived need that we should even be in this space, we're going to see a lot less involvement in acute care, maternal health, and pelvic health. So I really hope that from a student standpoint, it's something that you can be using to educate, other students, other classmates, colleagues that you'll have, but then even other future professionals, right, who want to serve this population, but they don't know how. They don't know how distinct they all are.
I'm just thinking back to when you initiated this collaboration. And you might have mentioned this today, but you said this is probably one of the most asked questions in pelvic health and in general. And I've had so many of my patients in this field work ask, wait, you're an OT? Like, what's the difference between you guys? I just feel like this handout will be amazing, not only for pelvic health, but also just generally too. So I feel like, I'm just really excited and grateful.
Absolutely. Thank you so much for your work. Thank you so much for your time, Becca Downs. And I look forward to speaking with you again.
Can I just say one more thing that I think is really important is that as our scopes expand, not just within the traditional rehab world, but also with nursing and with caregivers and clients, and with that spirit that you voiced, Rebecca, about endeavoring not to reproduce colonial and imperial systems through our work, which is just as important in the occupational therapy world as it is within the physical therapy world. It's important to realize that none of us own these practices, and it's okay to give ourselves permission to be similar when we're putting the client first and keeping things simple. And there is no human being that has, or I hope, I don't really want a world where somebody patents taking vital signs and makes it so that only this king on a hill is the only one that can take vital signs. We actually want to teach our clients and be empowered to advocate and gain health literacy. And if we collaborate, even with the janitorial staff, that it feels empowered to comment that they saw someone fainting and vomiting on the way to the thing. It's just that moment of self-reflection where we could be putting the hypervigilance and the scarcity and the toxicity of for-profit healthcare. Notice when we might be utilizing and leading with our own emotions and our own fear of scarcity. Human beings are allowed to be similar and they're allowed to be different, and we can communicate mindfully and collaborate with how we bill and how we navigate these policy systems, I think it's important to appreciate that OT and PT are two different professions and disciplines and regulatory structures and credentialing, but we're also human beings. And it's important to know that there's going to be overlap. And if we're doing this job well, there's going to be overlap because we need carryover across all the occupations in the day. And that takes a village. Just because we have these modern villains doesn't mean that it's still not, we're still tribal beings. So we need to learn how to share and make sure that we're not putting our own individual scarcity mindsets first, and realize that, hey, there's a lot of medical neglect out there, more than enough patients for everybody. So let's learn how to share and document appropriately so that we're not a financial liability to our organization that has interest in having quality patient outcomes. If we can get beyond that, this stuff gets a lot easier.
I completely agree. Thank you so much, Dr. Jarvis. I'll close with that. Dr. Jarvis, I mean, she hit on a point that really, I think, honestly brings us full circle. I'm personally a part of a lot of different groups, as you can say, professional groups. Lindsay Vestal is the founder of the OTs and Pelvic Health Summit, or the co-founder. She's actually collaborated on this event that happens annually. And it's kind of an event that was founded to create almost this camaraderie around occupational therapists who are entering into the field of women's health, specifically pelvic health. And she every year invites other professions, other disciplines, even though it's named OTs and pelvic health. She's very welcoming to other professions. And she's invited me into her circles time and time again. I'm also a part of a group of professionals called the Women of Color Pelvic Floor Physical Therapy Directory. And that group, I just did a retreat with, is not open to disciplines outside of women of color or people, individuals, practitioners, and it's not open to anyone who identifies as a pelvic health OT. How can I be a part of two communities that are very different from one another? It's because, and I want this to be very clear to the audience here and the audience that will be watching later, is that there is a difference in my mind, in my opinion, between community and practice. Your community does not dictate how you practice, right? So when we're talking about scope of practice and you're getting pushback, whether it's from another discipline who doesn't believe as an occupational therapist you should be treating the pelvic floor, or if it's from a community of providers who don't feel that your services are needed as an acute care OT or PT, well, that's a community, but they don't dictate your practice. And so the goal there and the recommendation I have for you all is this, is that you find a community that you can thrive in. I happen to be a part of a lot of different communities. My people are kind of scattered, if you will, because within each of those communities, whether it's the OTs and pelvic health, or whether it's the women of color pelvic floor physical therapists, I'm finding people that align with my belief that both disciplines are absolutely beneficial to a population that should not be as vulnerable as they are in the United States of America in 2023, where we all are currently experiencing the kind of trauma from their stories and from their experiences. No one at the time of their pregnancy and at birth should be walking around with acute heart failure and no one's checking in on them. And so I've decided that early on in my career, my community would be anyone and everyone who could be on the team, who can hand off for that patient, who could be in every single setting where that person could possibly be in. And so I started collaborating with occupational therapists before I even became a licensed physical therapist. I learned early on that collaboration was beneficial more to the patient than anyone else. And so I'm a part of a lot of different communities, but I don't let those communities dictate how I practice. And so I leave you with that the main difference between OTs and PTs in pelvic health is that we are two separate disciplines, that we do have interventions that cross over, but that holistically, from the core of us, we want the best for our patients. We do that in different ways, and it's really dictated by our expertise, by our experience level, and by also the person in front of us and what their journey has been up until this point. And so I hope that you all have gotten something out of tonight, that you've all learned a little bit more about the work that we're doing for the maternal population, but also for anyone after a major pelvic surgery. And please, if you ever wanted to connect, I'm Rebecca Seagraves. I'm the CEO of the Pelvic Health Network. I'm excited that we are starting a certification that will certify the first perinatal health specialist in March of 2024. And if you want more information, please reach out to me, reach out to the Pelvic Health Network, and then reach out to the people in this room who shared their contact information as well. And you'll find that you will start building your community and can really move along care for populations that are very vulnerable here now in 2023. Thank you all for your time.